There are two ways to answer this question. The first way to answer is, are you going to capture more patients that will respond to treatment? And the second way is, when you capture these patients, would they respond better? And in both ways, when answering both of these questions, the answer is we outperform existing tests. So when it comes to capturing more patients, DeepHRD is going to capture between 1.8 and 3 times more patients than existing molecular tests. And again, when you look at those patients, you see a better separation of their survival after they're being treated. So we both capture more, and they have a better response. Initially, we expected that we'll be able to predict something, and we would be able to perform comparably or worse. It was quite surprising that we can outperform them. But then when we looked at why we can outperform them, is the model is going to pick up meaningful information. So it's going to pick up the presence of macrophages, the necrotic regions, things that we know biologically make sense, and things that can be detected from the tumor microenvironment, which usually you cannot see from a molecular test. When you do the next-gen sequencing test, right, it's going to tell you, well, you have some changes in the DNA, something has changed. But that doesn't mean actually you don't really know phenotypically where that has changed the cells, whether that has changed the microenvironment. What this test says, wow, the microenvironment, the cells have changed their shape, there's more immune infiltrates, there's more things happening around, the tumor looks different. So it's in a way, you look at the phenotype, which of course is underlined by the genotype, but it allows to use that information as a biomarker. What we did is we said, well, we're going to train on one set of patients, which are taken either from public repositories or from data that we have available. We're going to train the model on them. And when it comes to validation, we will get data from completely different people who have used completely different staining protocols, image taking protocols, etc. So our training cohort, most of it comes from the Cancer Genome Atlas, from this publicly available resource. Our clinical cohort, one comes from France, right? So a very, very different place. The other one comes from Memorial Sloan Kettering. Again, very different data generation process. And we also have an additional cohort that come from a Canadian Cancer Center to evaluate the model. We want to get this thing to the patients as fast as possible, right? We think this is something that will help them. We think this is something that everyone will benefit, right? Oncologists, they get to get a diagnosis faster. Pathologists, they get to do that and be in the centerpiece of precision oncology. Most importantly, patients, they get to treatment faster and cheaper. We think that the drug companies will be interested, again, because now you have a test that captures more people, does it faster, and it doesn't exhaust tissue, which is, again, a huge advantage for a number of reasons. The plan is to partner with drug companies with their clinical trials, where we use the digital information to be able to show retrospectively that this works for their specific PARP inhibitors. And then the plan is to go to the FDA for an approval.